Vanakkam. Once a decision has been taken to do a surgical treatment for an infant with birth brachial plexus palsy, the question is what surgery is to be done. This of course will depend upon the aim of the management, that is, what movements are we proposing to achieve. Then the strategy also depends on what nerve roots are available and what have been avulsed. And what is the role for nerve coaptation, what is the role for nerve grafting, and what is the role of nerve transfers. After all, we need to perform the best surgical procedure available to get the best result in these infants. And all these strategies have to be decided before we even explore the plexus in the infant. All these explained in this video. In this video, we are going to see what surgery needs to be planned for an infant with birth brachial plexus palsy. Because as we have seen in the previous videos, we have decided that we are going to do a plexus reconstruction, and we have also decided when to operate. But what is our strategy? If there is a rupture of the nerve or avulsion of the root, what should we do? So this will be the strategy which is going to be made part of our decision making before we actually go into surgery, so that we are well prepared. First of all, what is our aim in surgical reconstruction of the plexus in infants with birth brachial plexus palsy? Our aims are prioritized, and we have got 4 priorities. When doing a plexus reconstruction in the infant, the first priority is always restoration of hand grasp function. If it is already present, the next priority becomes the important goal. The second priority is restoration of elbow flexion. The third priority is restoration of shoulder movements. And the last priority is restoration of extension of elbow, wrist and fingers. To achieve all this, we need to have a strategy for surgical reconstruction. In other words, we need to plan a surgery. But what surgery needs to be planned? That depends on the number of available viable proximal spinal nerve stumps for grafting, or the nerve roots, cross-sectional area of the stumps, and availability of donor nerves for neurotization. But there are so many patterns of injury of the brachial plexus in the infant with birth brachial plexus palsy. How are we going to understand the strategy for each of these injuries? For convenience of understanding, the most common lesions are divided into 3 groups, group 1, 2 and 3. Let us see what these 3 groups are and how the strategies are planned in each group. Group 1 consists of lesions of C5 and C6, that is the upper trunk. Here the hand grasp function is normal, so the first priority of surgical intervention is restoration of elbow flexion followed by reanimation of shoulder movements. Group 2 consists of lesions of C5, 6 and 7, otherwise known as extended upper brachial plexus palsy. Here, elbow, wrist and finger extension are impaired along with the absent elbow flexion and shoulder movements. Group 3 consists of lesions of C5, 6, 7, 8 and T1, what is known as a pan palsy, resulting in a flail limb. The first priority here is restoration of hand function, followed by elbow flexion, then shoulder movements. So, selection of distal targets for hand function reinnervation is the key in the management of group 3. Now, let us see the detailed strategy of management in all these groups. Group 1, as we have already seen, consists of involvement of C5 and C6. Now, these roots that are involved can either be avulsed or ruptured, leading to a gap or a neuroma in continuity. This group can be divided into 3 types based on which root has been avulsed and which root is available for reconstruction. In type 1, both the C5 and C6 roots are ruptured, and hence both roots are present and can be used for reconstruction. In type 2 of group 1, the C5 root is present but the C6 root has been avulsed. So only one root is available as a donor for reconstruction. In type 3, both the C5 and C6 roots have been avulsed. So, there are no donor roots available for reconstruction. Let us see what strategy we can plan for group 1 type 1 where both the C5 and C6 roots are available. If this represents the normal brachial plexus, in a group 1 type 1 lesion, we will have a neuroma and continuity on both the C5 and C6 roots. The first thing is we need to resect the neuromas. There is not much of a role for neurolysis in these infants because remember, we have made a decision to operate because of the poor return of function. The gap that occurs as a result of excision of the neuroma at about 5 months of age is usually 2.5 to 3.5 centimeters, necessitating the harvest of sural nerves from both legs. The length of each harvested sural nerve is usually 11 to 13 centimeters. We will need approximately 6 cables for the reconstruction. The first strategy of reconstruction would be to apply one reversed nerve graft from C5 to suprascapular nerve. The coaptation should be performed in the rostroventral quadrant of the C5 cross-sectional area because that is where the fibers for shoulder abduction are traveling in the C5 root. This is very important since we are using a single nerve graft, so we need to be accurate regarding the type of fibers that we are transmitting to the suprascapular nerve. This procedure should take care of initiation of shoulder abduction. The second strategy should be to apply two grafts from C5 to the posterior division of the upper trunk to get back shoulder external rotation and augmentation of the shoulder abduction by neurotization of the deltoid. The third strategy would be application of 3 or 4 grafts of sural nerve from the root of C6 to the anterior division of the upper trunk to get back elbow flexion. If the size of the C5 and C6 roots is small or the quality of the roots is not good enough, we can reduce the amount of load on these roots by performing a spinal accessory nerve to suprascapular nerve transfer for initiation of shoulder abduction. We also need to note that there may be an involvement of the C7 root also, which may need a neurolysis, which can be done after intraoperative nerve stimulation to make sure that it is stimulatable. Now we come to the surgical strategies for group 1 type 2 pattern of injuries. As we have already seen, in this type C5 root is present but C6 root has been avulsed. So only one root, that is C5 alone, is available for reconstruction. So in this type we will note a neuroma in the C5 root but avulsion of the C6 root. After resecting the neuroma in the C5 root, the dorsal root ganglion of the avulsed C6 root is identified and the dorsal root of the C6 and the dorsal filaments are excised. This is to make sure that only the ventral filaments which contain the motor fibers to get back elbow flexion are retained. We also need to prepare the suprascapular nerve and the posterior division of the upper trunk to be recipients of nerve transfers. Now, nerve grafts from the C5, that is the posterior aspect, are applied to the posterior division of the upper trunk to get back deltoid and shoulder external rotation. Spinal accessory nerve to suprascapular nerve transfer is done for initiation of shoulder abduction. For elbow flexion and supination, the anterior root filaments of the avulsed C6 root that we have separated can be transferred to the caudal aspect of C5 with direct coaptation, or if not possible, nerve grafts can be used. Medial pectoral nerve transfer to the musculocutaneous nerve can be considered in addition. If this is done, the coaptation of the anterior root filaments of C6 to C5 will then contribute only to the brachioradialis muscle reinnervation. Also, the medial supraclavicular nerve, which is a part of the ansa cervicalis, can be transferred to the posterior filaments of the avulsed C6 root if they have been retained to provide sensation. Though so many options are available, the factors that determine the strategy are the cross-sectional area of the posterior division of the upper trunk the availability of sural nerve grafts, the quality of the anterior root filaments of C6 and the coaptation site to the C5 root. Group 1, as we know, represents lesions of the C5 and C6 roots. Type 3 represents where both these roots have been avulsed. So, no roots are available in the plexus for reconstruction. Here you can see a representation of the avulsed C5 and C6 roots. We have to depend entirely on nerve transfers for the reconstruction in such cases. The spinal accessory nerve can be transferred to the suprascapular nerve for shoulder abduction initiation. The medial pectoral nerve can be transferred to the musculocutaneous nerve for elbow flexion. Oberlin transfer, that is, ulnar nerve fascicle to the nerve to biceps, and the median nerve fascicle transfer to the nerve to brachialis can be done if the proximal procedures fail or the patients present late. That is because these techniques also carry theoretical potential risks for the growing hand. Now we come to group 2 lesions where the involvement is of C5, C6 and C7 roots and occasionally involvement of C8 root also. These patients usually retain finger grasp function, so restoration of hand function is not a goal of surgical intervention. However, in this group, elbow, wrist and finger extension are impaired in addition to absent elbow flexion and shoulder movements. Group 2 lesions can be divided into 5 types based on the involvement of the roots. Among the group 2, in type 1, all 3 roots are ruptured, so all 3 roots are available for use in reconstruction. In type 2, C5 and C6 roots are present while C7 has been avulsed. In type 3, only C5 root is present and C6 and C7 have been avulsed. In type 4, C6 alone has been avulsed, C5 and C7 roots are available, and in type 5, both the C5 and C6 roots are available, just as in type 2, but there is an additional avulsion of the C8 root also in these patients. So what are the surgical strategies in group 2 type 1 where all 3 roots are present? First, we will need to resect the neuroma of the C5 and C6. Sural nerves need to be harvested from both legs and if necessary, the superficial branch of the radial nerve from the affected side in preparation for reconstruction using nerve grafts. We must remember that it is not only the C5-6 neuromas that we need to reconstruct, but also the C7 neuroma. As you can see in this representative diagram, the neuromas of C5, 6 and 7 have been resected. C5, C6 and C7 nerve roots are available for use in reconstruction. Nerve reconstruction for the C5-6 neuroma gap is similar to group 1 type 1 where we saw the management when both C5 and C6 roots were available. In addition, here we need to manage the C7 neuroma gap also. But since this is not absolutely essential, the reconstruction is based on the availability of graft material and the C7 neuroma is either resected or undergoes extensive neurolysis. Neurolysis is better only if some fascicular continuity is seen within the neuroma. If excess nerve grafts are available, they can be applied from the C7 root to the middle trunk. In group 2, type 2, we have seen that 2 roots are available. So we need to have a strategy for the C5-6 neuromas and also the avulsed C7 root. For the C5-6 neuromas, we have seen the type of reconstruction which we had discussed in group 1 type 1 lesions. That can be followed. The avulsed C7 root is transected as proximally as possible and the dorsal root ganglion is dissected from the ventral root and resected. Now, a direct coaptation from the caudal aspect of C6 proximal stump to the C7 ventral root filaments can be done or a nerve grafting can be done. For sensory restoration, a direct coaptation of the medial supraclavicular nerve arising from C4 to the postganglionic sensory part of the C7 root to innervate the C7 dermatome in the hand. But if this is to be done, the dorsal root filaments should not be excised. In group 2, types 3, 4 and 5 are rare. In type 3, only C5 root is present whereas C6 and C7 roots are avulsed. And in type 4, C5 and C7 roots may be present only C6 may have been avulsed. So in type 3, there will be a C5 or upper trunk neuroma in continuity with C6 or C7 avulsion. In type 4, the C5 root will be available, but in addition C7 neuroma will also be present, indicating that C7 root may also be available. Here you can make out that C5 root alone is available, whereas C6 and C7 have been avulsed. Sometimes C8 root may also be avulsed in this condition. So what can be done is graft repair from C5 to the posterior division of the upper trunk to get back shoulder external rotation, direct coaptation of the ventral root filaments of C6 to the caudal aspect of the proximal C5 nerve stump will be the strategy to restore elbow flexion. Spinal accessory nerve to suprascapular nerve transfer for initiation of shoulder abduction. C8 root may also be avulsed. The C7, C8 avulsed roots are left in situ. For type 3 lesions, if the only available C5 proximal nerve stump is small and cannot accommodate the ventral fibers of the C6 root, it is better to do a medial pectoral nerve transfer to musculocutaneous nerve for restoring elbow flexion. In the fifth type of group 2 lesion, both the C5 and C6 are available, but C7 root has been avulsed. As you can see, type 5 includes a C8 nerve root avulsion injury. Type 5 lesions are usually reconstructed similar to type 2 lesions, which we have discussed earlier. The C8 roots are left in situ. In group 3 lesions, as we have already seen, C5, C6, C7, C8 and T1, that is, all the roots of the brachial plexus have been involved. 3 roots may have had ruptures with avulsions of the remaining 2, or 2 roots may have had ruptures, or even a single root may have a rupture, whereas the other roots may have been avulsed. So here only one root will be available for reconstruction. In the extreme situation, all the roots may have been avulsed. However, complete nerve root avulsion of all the roots is very rare. Sometimes C5 and C6 may have postganglionic lesions, that is rupture, and C7, C8, T1 may have preganglionic lesions or avulsions. So in this situation, C5 and C6 proximal stumps are available for reconstruction. But sometimes only one root will be available, either C5 or C6. Keeping this in mind, the first strategy would be to divide the C8 and the T1 roots into their respective motor and sensory parts at the neural foramen without violating the vertebral artery. This is the part of the C8 root which is mainly motor, that is the ventral part, and it is the dorsal part that contains the motor fibers in the T1 root. As far as the sensory fibers are concerned, they are found mainly in the dorsal and caudal part of C8 root and ventral part of the T1 root. Splitting the distally avulsed roots in this fashion will ensure that the appropriate nerves will get neurotized. Now the strategy is going to depend on how many roots are available, 2 or 1. When 2 roots are available, that is C5 and C6 roots, nerve grafts from the C5 root to the posterior division of the upper trunk are used for shoulder external rotation. The C6 root can be connected with the anterior filaments of the C8 root via direct coaptation for hand function. If the C6 root is thick enough, the T1 can also be connected in the same way. If direct coaptation is not possible, grafts can also be used in this situation. To achieve initiation of shoulder abduction, spinal accessory nerve transfer can be done to the suprascapular nerve, and nerve grafts can be used from the remaining part of the C6 root to the anterior division of the upper trunk to get back elbow flexion. To provide sensation on the important parts of the functioning hand, graft or direct coaptation from the supraclavicular nerves to the sensory portions of C7 and C8 can be done. When only one proximal stump is available as a donor for nerve repair or reconstruction, it is used entirely for restoration of hand function. This is done by connecting the C5 root with the C8 root and if possible T1 root also, and this can be done either by direct coaptation or with grafts. Restoration of elbow flexion is achieved with the intercostal nerve transfer to the musculocutaneous nerve, and restoration of shoulder movement can be achieved with spinal accessory nerve to suprascapular nerve transfer. Summarizing, we can say that when we want to achieve shoulder abduction, the recipient nerve is usually the suprascapular nerve. The donor can be either the spinal accessory nerve or the rostral part of C5 root. When we want to achieve shoulder external rotation, the recipient nerves or the nerve fibers can be the posterior division of the upper trunk, or a little more distally the anterior branch of the axillary nerve. The donors can be any of the available roots which are healthy. To achieve elbow flexion, we can neurotize to either the anterior division of the upper trunk, or a little more distally the musculocutaneous nerve, or directly to the nerve to biceps or nerve to brachialis. The donor can be any of the available roots that are healthy, the intercostal nerve, or the median ulnar nerve fascicles as in the Oberlin transfer, or even the medial pectoral nerve. Because we may need a lot of nerve grafts in the surgery of birth brachial plexus palsy, the available nerve graft donors are bilateral sural nerves, medial antebrachial nerve on the affected limb, or the superficial sensory branch of the radial nerve on the affected limb. Similarly, when we think of reconstruction of the plexus, we need to have as many donor nerves as possible to provide neurotization of the distal denervated muscles. We can use the C5, 6, 7 roots if possible, the spinal accessory nerve, the medial pectoral nerve, the contralateral C7 can also be used, the intercostal nerves, and cervical plexus can also be used. Now we know the strategies of reconstruction of the brachial plexus in birth brachial plexus palsy. We know what nerve can be used as a donor, what nerve can be used as a recipient when there is a rupture of the roots or avulsion of the roots. The question is, how are we going to identify the plexus and parts of the plexus in the infant, and how to identify an avulsion, or how to identify whether the available root is good. All that in the operative techniques video which will be following in this series. I hope you liked the video. I enjoyed making it. Please do click on the shown links to see more about clinical features in birth brachial plexus palsy and the different investigations that can be done in this condition. And do not forget to subscribe to stay connected with the latest in learning hand surgery, plastic surgery, trauma surgery and ethics. Vanakkam.